There is a moment that most people over 60 recognize, standing at the bathroom mirror in the morning light, or noticing the brush after running it through your hair, or catching a glimpse of the scalp beneath, and registering, with a quiet unease that is difficult to name, that something has changed, that the hair is not what it was, that the parts are wider, that the ponytail that once required 2 wraps around a hair tie now wraps 3 times around a thinner one, that the temples are more visible than they used to be. For most people, the first response is to chalk this up to aging, to accept it as the natural, inevitable biology of getting older, to buy a volumizing shampoo perhaps, or try a different style that masks what has changed, to dismiss it. What most people do not know, and what most physicians do not tell them unless they ask specifically, is that hair thinning after 60 is frequently not simply aging. It is often a signal, a specific, readable, diagnostically meaningful signal that the body's internal balance has shifted in ways that the hair follicle, one of the most metabolically active and hormonally sensitive structures in the human body, is expressing through changes in density, texture, growth rate, and distribution. Today, from the perspective of dermatological science and the research on the relationship between systemic health and hair biology, we are going to talk about 4 silent health problems that express themselves through specific patterns of hair thinning in adults over 60, problems that, in many cases, are entirely treatable when identified, and that can be identified through simple laborato-RI testing that most people have never been specifically directed to pursue. This video is not designed to cause alarm about every strand of shed hair. Daily hair loss of 50 to 100 hairs is entirely normal. The scalp has approximately 100,000 follicles, and each follicle cycles through growth, transition, and resting phases in a continuous process of renewal. What we are discussing is pattern hair loss, texture change, and the specific distribution of thinning that differs meaningfully from normal shedding and that correlates with identifiable internal health conditions. Understanding the biology of the hair follicle is the starting point, because it is that biology that explains why systemic health conditions express themselves so visibly in the hair. The hair follicle is a miniature organ. Each one contains a complex of cells: the dermal papilla at the base of the follicle, the matrix cells that divide rapidly to produce the hair shaft, the inner and outer root sheaths that structure the growing hair, and the erector pili muscle. The follicle cycles through 3 phases: the anagen phase, active growth, lasting 2 to 7 years, the catagen phase, a brief transition period of 2 to 3 weeks, and the telogen phase, a resting period of 2 to 3 months before the hair sheds, and a new anagen cycle begins. What makes the hair follicle so exquisitely sensitive to systemic health changes is its metabolic demand. The matrix cells of the actively growing hair follicle divide more rapidly than almost any other cell type in the human body, a rate of division that requires consistent, uninterrupted delivery of oxygen, energy substrates, amino acids, and the specific micronutrients that support cellular replication. Simultaneously, the follicle is richly endowed with hormone receptors, particularly receptors for androgens, thyroid hormones, estrogen, and several growth factors that regulate the duration and vigor of the anagen growth phase. The hair follicle is one of the few structures in the adult body that undergoes complete cyclical regeneration, full structural dismantling and reconstruction, thousands of times over a person's lifetime. At the end of each telogen resting phase, the follicle must rebuild its entire lower portion from stem cells that reside in the bulge region of the follicle wall. This stem cell activation requires the same nutrients, hormonal signals, and growth factors that support stem cell function elsewhere in the body. What this means practically is that the hair follicle's regeneration cycle is a continuous assay of the body's capacity to support stem cell function, a capacity sensitive to metabolic stress, hormonal change, inflammatory signaling, and nutritional adequacy in ways that are visible in a way that most other internal processes are not. When something disrupts stem cell activation at the beginning of a new anagen cycle, the follicle may remain in a prolonged telogen phase, a state called kenogen, in which the follicle is empty, neither growing nor shedding, that reduces overall hair density without dramatic shedding. This gradual density loss is precisely what makes it so easy to attribute to aging rather than to a specific, addressable internal cause. The 4 conditions we are about to describe are the most common and most clinically significant systemic causes of hair thinning in adults over 60. Conditions that produce recognizable patterns of hair change that serve as accessible, visible diagnostic windows into internal processes that might otherwise remain silent for months or years. The first silent health problem is hypothyroidism. underactivity of the thyroid gland, and it is the single most common systemic cause of diffuse hair thinning in women over 50, affecting approximately 10% of women over 60 and a smaller but clinically significant proportion of men. The thyroid gland produces thyroxine and triiodothyronine, the hormones that regulate the metabolic rate of virtually every cell in the body, including the highly metabolically demanding matrix cells of the hair follicle. When thyroid hormone levels fall, whether through autoimmune thyroid disease, which is the most common cause in older adults, through post-surgical hypothyroidism, or through the gradual decline in thyroid function that can accompany aging, the metabolic rate of the hair follicle matrix cells falls with them. The anagen phase shortens. More follicles than normal enter the telogen resting phase simultaneously. Hair density decreases. Hair texture changes. The hair typically becomes dry, coarse, and brittle, losing the shine and elasticity that it had when thyroid function was optimal. The pattern of hypothyroid hair loss is characteristically diffuse, affecting the entire scalp rather than concentrating at the hairline or crown, and it frequently involves the outer third of the eyebrows as well, a finding that dermatologists call the sign of Hertoga, and that is one of the most specific physical findings in hypothyroidism. The combination of diffuse scalp thinning, loss of the outer eyebrow, dry skin, fatigue, cold intolerance, and unexplained weight gain creates a recognizable clinical picture. But each of these features individually is common enough to be attributed to aging, which is precisely how hypothyroidism remains undiagnosed for years in a substantial proportion of affected older adults. The most common cause of hypothyroidism in adults over 60 is Hashimoto's thyroiditis, an autoimmune condition in which the immune system produces antibodies against thyroid tissue, gradually destroying the gland's hormone-producing capacity. Hashimoto's frequently exists in a subclinical state, with TSH already elevated but thyroid hormone levels still within the normal range, for years before clinical hypothyroidism develops. The hair follicle, which is acutely sensitive to thyroid hormone signaling, may already be responding to the suboptimal hormonal environment before the standard diagnostic threshold for treatment is reached. The complete evaluation of thyroid status goes beyond TSH to include free T4, free T3, and thyroid antibody testing, anti-TPO and antithyroglobulin antibodies, that identify the presence of Hashimoto's thyroiditis specifically. The diagnosis of hypothyroidism begins with a thyroid-stimulating hormone test, TSH, in a single blood draw. Treatment with levothyroxine, the synthetic thyroid hormone replacement that has been used safely for decades, restores thyroid hormone levels, and hair regrowth typically follows over 3 to 6 months of stable, adequate treatment. The hair does not regrow overnight. The hair cycle means that the effects of improved thyroid function take 3 to 6 months to become visible as new hair growth. But the regrowth is real and represents one of the most gratifying clinical outcomes in dermatology. The second silent health problem is iron deficiency, specifically, low ferritin levels that may not be captured by standard complete blood count testing, and that represent the most common nutritional cause of hair thinning in women of all ages, including those well past menopause. Iron plays a critical role in the hair follicle through multiple mechanisms. It is required for the activity of ribonucleotide reductase, the rate-limiting enzyme in DNA synthesis in dividing cells, meaning that iron deficiency directly impairs the rapid cell division that produces the hair shaft. It is required for adequate oxygen delivery to the metabolically demanding follicle, and it is stored in the follicle itself. The dermal papilla contains iron stores that are preferentially mobilized when systemic iron availability is insufficient, suggesting that the follicle is acutely sensitive to changes in iron status before those changes become apparent in standard hematological markers. The critical point for adults over 60 is that iron deficiency can occur without anemia, without the low hemoglobin that standard blood count testing detects. A study published in the Journal of the American Academy of Dermatology found that serum ferritin levels below 40 nanograms per milliliter were significantly associated with hair loss in premenopausal and postmenopausal women, while hemoglobin levels remained in the normal range, meaning that the standard anemia test would have shown no abnormality, while the hair follicle was already functioning. Iron depleted. The gap between the standard laboratory report and clinically relevant information is one of the most consequential in routine medical care for older adults experiencing hair thinning. When a ferritin result comes back at 18 nanograms per milliliter labeled within the normal reference range, a patient may be told her iron is fine. But the dermatological research suggests that optimal ferritin for hair follicle function is approximately 70 nanograms per milliliter, substantially higher than the lower limit of the normal reference range. A woman with a ferritin of 22 nanograms per milliliter who is told her iron is normal may spend years trying topical treatments while the true cause of her thinning remains unaddressed. For adults over 60, the causes of iron depletion without frank anemia include reduced dietary intake of hemi-iron, impaired absorption due to reduced gastric acid production or proton pump inhibitor use, and subtle gastrointestinal blood loss from polyps, vascular abnormalities, or early colorectal cancer. The investigation of iron deficiency in an older adult should include a gastrointestinal evaluation if no clear dietary explanation is apparent, because chronic gastrointestinal blood loss is a medical concern that should not be overlooked. Iron supplementation requires 6 to 12 months of consistent use to raise ferritin to the optimal range for hair follicle function. Before we continue, here is a pause for you. Have you had your TSH and ferritin tested recently? Have you discussed hair thinning with your physician and received a blood test evaluation? Or has the conversation been limited to topical treatments and acceptance? Drop a comment below right now. Tell us whether any of the first two conditions resonate with your experience, or whether you have already been diagnosed with one of them. Your experience is valuable to everyone watching this video, and your comment directly shapes the content we create for this community. The third silent health problem is nutritional deficiency beyond iron, specifically the complex of micronutrient deficiencies that become more common in adults over 60 due to changes in absorption efficiency, dietary variety, and the metabolic demands of aging. Zinc, biotin, vitamin D, selenium, and certain amino acids, particularly lysine and cysteine, which are the primary structural components of the keratin protein that makes up the hair shaft, are all required in adequate supply for optimal hair follicle function, and all are commonly deficient in the diets of older adults. Zinc deficiency produces a specific pattern of hair change, diffuse thinning with characteristic dryness and reduced luster. A systematic review published in the journal Dermatology and Therapy found that serum zinc levels were significantly lower in patients with alopecia areata and telogen effluvium than in healthy controls, and that zinc supplementation produced significant improvements in hair density in zinc-deficient patients. Vitamin D deserves specific attention because the vitamin D receptor, VDR, is relevant here. Its receptors, or VDR, specifically the VDR, are expressed in the dermal papilla cells of the hair follicle, and vitamin D signaling is now understood to regulate the transition between anagen and catagen phases of the hair cycle. Low vitamin D levels have been associated with multiple forms of hair loss in observational studies. A study published in the International Journal of Dermatology found that adults with telogen effluvium and alopecia areata had significantly lower vitamin D levels than controls. For adults over 60, vitamin D deficiency is nearly universal without supplementation. The skin's capacity to produce vitamin D from sun exposure declines significantly with age, and the conversion of vitamin D precursors to the active form in the kidney becomes less efficient. Many experts recommend 1,000 to 2,000 international units daily to maintain serum vitamin D levels above the threshold associated with adequate hair follicle function. Biotin, vitamin B7, has been extensively marketed as a hair health supplement, and while true biotin deficiency is relatively uncommon, it produces a recognizable syndrome of diffuse hair thinning, brittle nails, and skin changes. A key practical note: high-dose biotin supplementation can interfere with thyroid function laboratory tests and cardiac troponin assays, producing falsely elevated or falsely lowered results that can lead to misdiagnosis. Any adult taking high-dose biotin supplements should inform their physician and laboratory before blood tests are drawn. The fourth silent health problem is hormonal imbalance beyond thyroid disease, specifically the androgenic hormonal changes that become increasingly prevalent in both men and women after 60, and that produce pattern hair loss through a well-understood mechanism involving the miniaturization of hair follicles in specific scalp distributions. In women, the significant decline in estrogen that occurs during and after menopause alters the androgen to estrogen ratio in ways that expose the hair follicle to the effects of dihydrotestosterone, DHT, a potent androgen that binds to receptors in the dermal papilla of genetically susceptible follicles and progressively shortens the anagen phase, reduces the follicle size, and produces progressively finer, shorter, and less pigmented hairs. The pattern in women is characteristically a widening of the central part and a reduction in density across the crown, preserving the frontal hairline, a distribution captured in the Ludwig classification of female pattern hair loss. The clinical significance of hormonal pattern hair loss extends beyond cosmetics. Research published in the British Medical Journal found that men with vertex baldness, crown pattern hair loss, had a significantly higher risk of coronary heart disease than those without pattern hair loss, with proposed mechanisms involving shared genetic variants that influence both androgen sensitivity and cardiovascular risk factors. Pattern hair loss is therefore not merely a cosmetic concern but a potential cardiovascular risk marker worth discussing with a healthcare provider. For women experiencing postmenopausal androgenetic alopecia, the evaluation should include assessment of androgen levels, total and free testosterone, DHEAS, to exclude ovarian or adrenal sources of excess androgen production that are treatable and that, if unaddressed, drive progressive hair loss regardless of topical treatment. Beyond the 4 specific health conditions, the diet and lifestyle factors that support hair follicle health in adults over 60 complete the picture. Protein adequacy is foundational. Hair is made of keratin, and the matrix cells that produce the hair shaft require a continuous supply of amino acids, particularly cysteine, methionine, and lysine. Adults over 60 who have significantly reduced their protein intake may have suboptimal amino acid availability for follicle function. The recommended daily protein intake for adults over 60, approximately 1.2 to 1.6 grams per kilogram of body weight, supports not only muscle preservation but the ongoing keratinization process that produces healthy hair. Omega-3 fatty acids support the lipid layer of the hair shaft and reduce the scalp inflammation that contributes to follicle miniaturization. Antioxidant-rich foods reduce the oxidative stress that accumulates in the aging scalp and damages the stem cells of the hair follicle bulge region. The Mediterranean dietary pattern, extensively validated throughout this channel for cardiovascular, metabolic, and longevity outcomes, is also, it turns out, one of the most follicle-supportive dietary patterns available, providing the protein, iron, zinc, omega-3 fatty acids, vitamin D from fish, and antioxidant polyphenols that the hair follicle requires. Chronic psychological stress drives telogen effluvium, the simultaneous shift of large numbers of follicles into the resting phase that produces diffuse shedding, through cortisol's disruption of the follicle growth cycle, via glucocorticoid receptor signaling in the dermal papilla cells. For adults over 60 managing the chronic stressors of aging, stress management practices that reduce cortisol levels are simultaneously hair follicle protection strategies. Sleep adequacy completes the picture. Growth hormone, which promotes follicle entry into the anagen growth phase, is secreted primarily during deep sleep stages. Adults who consistently sleep fewer than 7 hours may be experiencing growth hormone availability that contributes to reduced anagen phase vigor. The scalp microbiome, the community of microorganisms inhabiting the scalp surface, has emerged in recent research as an additional variable in hair follicle health relevant to the older adult population. The scalp microbiome changes with age, shifting toward greater abundance of Malassezia species, the fungal organisms associated with seborrheic dermatitis and scalp inflammation, and a reduction in the bacterial diversity that characterizes a healthy scalp surface. Chronic scalp inflammation driven by microbiome disruption has been documented to shorten the anagen phase of the hair cycle and contribute to follicle miniaturization in susceptible individuals. Appropriate scalp hygiene, avoidance of harsh detergents, and in some cases the use of zinc pyrithione or ketoconazole-containing shampoos can support scalp microbiome health as a relevant modifier of the hair follicle's response to systemic health challenges. Alopecia areata, the autoimmune condition in which the immune system attacks hair follicles directly, producing the characteristic circular patches of complete hair loss on the scalp, eyebrows, or body, deserves specific mention in the context of the 4 silent health problems, because it frequently co-occurs with autoimmune thyroid disease. Adults who present with both diffuse hair thinning, consistent with hypothyroidism, and patchy hair loss warrants an evaluation that specifically considers the overlap between autoimmune thyroid disease and alopecia areata, as both conditions may require simultaneous treatment through different mechanisms. Alopecia areata is now the subject of an exciting new therapeutic era with the approval of JAK inhibitor medications that have shown significant efficacy in severe cases, a development that represents one of the most important advances in dermatology of the past decade. The relationship between gut health and hair follicle function is an emerging area of research that, while not yet established as definitively as the 4 conditions discussed in this video, warrants mention because it connects to the broader health principles we discuss throughout this channel. The gut microbiome influences systemic inflammation, nutrient absorption efficiency, and the bioavailability of the minerals, zinc, iron, selenium, that the hair follicle requires in adequate supply. Adults over 60 with compromised gut health, whether from antibiotic use, proton pump inhibitor therapy, or the natural reduction in gut microbiome diversity that accompanies aging, may have impaired absorption of the nutrients that the hair follicle depends on, even when dietary intake appears adequate. Supporting gut health through fermented foods, prebiotic fiber, and the avoidance of unnecessary microbiome-disrupting medications is therefore an indirect but genuine strategy for supporting hair follicle nutritional status in older adults. Hormone replacement therapy, HRT, and its relationship to hair health in postmenopausal women is a nuanced topic that deserves honest acknowledgement. Estrogen has direct protective effects on the hair follicle, promoting the anagen phase and countering the DHT-mediated miniaturization that drives androgenetic alopecia. For women in whom the decline in estrogen following menopause is a significant driver of hair thinning, HRT, when appropriate from an overall health perspective and prescribed under medical supervision, may provide hair-related benefits alongside its other documented effects on bone density, cardiovascular health, and menopausal symptoms. The decision to pursue HRT is a medical and personal one that involves weighing benefits and risks in the context of the individual patient's overall health profile. But hair health is a legitimate consideration in that conversation, and one that should be explicitly included when a postmenopausal woman presents to her physician with accelerating hair thinning. Now let us bring together the practical picture, because the diagnostic information is only valuable if it translates into action. Any adult over 60 who is experiencing progressive hair thinning should request a specific blood panel from their physician that includes TSH, free T4, serum ferritin, complete blood count, serum zinc, serum 25-hydroxyvitamin D, and for women with suspicion of androgenic hair loss, total and free testosterone and DHEAS. This panel covers the most common and most treatable systemic causes of hair thinning in older adults, and its results may reveal conditions with significant health implications well beyond the hair. The conversation with the physician should include not just the hair thinning but the associated symptoms: fatigue, dry skin, cold intolerance, weight change, mood changes, that provide the clinical context that transforms a hair complaint into a systemic health investigation. The dermatologist who examines the scalp can assess the pattern of hair loss, the degree of miniaturization of individual hairs, and the presence of associated findings, eyebrow changes, nail changes, skin texture, that refine the differential diagnosis and guide the laboratory evaluation. Hair thinning after 60 is common. It is not inevitable, and it is not uniformly the result of aging alone. In a substantial proportion of cases, it is the hair follicle communicating, in the only language available to it, that something in the body's internal environment has shifted in a way that warrants investigation. The 4 conditions described in this video, hypothyroidism, iron deficiency, nutritional deficiencies, and androgenic hormonal imbalance, are among the most common of those shifts, and they are all identifiable through standard laboratory testing and addressable through specific evidence-based treatment. The mirror is not the enemy. It is the first diagnostic tool. Learning to read what it shows, specifically scientifically, with the knowledge that the hair follicle is a messenger and not merely a cosmetic concern, is the beginning of the kind of proactive, informed engagement with your own health that this channel exists to support. If this video gave you something specific, a blood test to ask for, a conversation to have, a symptom connection you had not previously made, please support this channel. Hit the like button right now, subscribe so you never miss a video, and leave a comment below. Tell us whether you have experienced hair thinning after 60, whether you have had a laboratory evaluation for the causes we discussed, and what you discovered. We read every comment. Your experience is not only valuable to you, it is valuable to every person in this community who is navigating the same question. Your hair has something to tell you. Now you know how to listen. Thank you for watching. We will see you in the next one.